Okay, so let us start with muscles. Okay, so we are going today to cover a little the most common pathologies about the muscle, the soft tissue, and we are going to go back to the bone and talk about some diseases and lesions that occur in the bone. So first of all, we have to know what's the normal histology of the muscles. As you know, regarding myocytes, we have skeletal muscle bundles that are composed of muscle fibers. We have two types of fibers, type 1 and type 2 fibers. We have different stains that can highlight the differences, highlight type 1 or highlight type 2 fibers. Here, this stain is the ATPase stain. Actually, in the ATPase stain, the darker fibers are type 2 fibers. So, type 2 fibers, muscle fibers, are dark in ATPase stain. The difference between type 1 and type 2 is the pathway of producing energy. In type 1, it's oxidative pathway. In type 2, it's glycolytic pathway, and we call the type 1 fibers are the slow twitch fibers also. As you can see here, it looks like the checkerboard appearance or the checkerboard pattern. Now, another thing you have to know that type 1 fibers nerves are different from type 2 fibers. So there is one nerve that innervates, give branches to type 1, and there is another nerve that give innervation to type 2. Okay, so they have different innervation. This is important because in a while we are going to talk about innervation problems or denervation lesions. There is another stain that's the NADH stain that's opposite to the ATPase stain, because the NADH is an enzyme that localizes in the oxidative, it's an oxidative enzyme, so it's very rich where in type 1 fibers that depend on the oxidative pathway. So that's why, because type 1 fibers are rich in NADH enzymes, so they will be darkly stained by this stain, and type 2 fibers will stain lighter. So it's opposite to the ATPase, okay? Because NADH is rich where in type 1. It's richer, it have a lot of NADH enzymes, more than type 2. Now, we said they have different innervation. So the problem there, when we have accident, for example, or injury, cut wound, deep cut wound, that cuts the nerves, or any injury to the nerves that innervate one of the fibers. What happened that then this nerve injury is, as you know, they cannot be repaired, especially if it's a very long or severe part of it is injured, or a long part of the nerve is injured. So what happened is that the second part, the second nerve is going to re-innervate the muscle fibers, and here we will lose the checkerboard pattern. We will only have just one type of muscles being regenerating according to what is the nerve that is left and that is not injured. And if you look here, we have, this is the NADH stain again. حكينا, what are the dark one that are stained with NADH? Type what? Type 1. So most of the muscle fibers here are actually type 1, and we have only residual type 2 that are going into degeneration process, and degenerated and necrotic type 2 muscle fibers because of the nerve injury that occurred in this patient. So once you see this stain, you can tell that this is a problem of denervation and reinnervation pathology. Okay. Now we are going to talk about another muscle pathologies other than nerve problems. Now we have to cover the commonest pathologies. We are going to talk about dystrophies, what's called dystrophies, and myositis. From their names, myositis, they are what? They are inflammation into the muscle. So we are going to see what? inflammatory cells, okay? But dystrophies are not actually inflammatory process. So there are structural pathologies on the same structure of the muscles. So we have two most common, you have to know the commonest thing only at your stage. So the most common muscular dystrophy is called Duchenne muscular dystrophy, and we are going to cover also Becker's muscular dystrophy. So Duchenne and Becker's. Here in this picture, this is a picture, a microscopic picture from a patient with Duchenne muscular dystrophy. What happens from its name, it's actually a problem in a membrane protein in the skeletal fiber membranes. We call this protein dystrophin. And this dystrophin is being produced by gene that is called dystrophin gene. So they carry the same name, dystrophin gene, that produces the dystrophin protein on the membrane, localizes on the membrane to stabilize the muscle fibers. This dystrophin protein is present and inherited through the X chromosome. Okay, so that's why this disease is an X-linked chromosomal abnormalities that is recessive. So if there is a female patient carries this this mutation, gene mutation, it will usually show no manifestation because it's recessive and she can compensate with the other copy from the other X from her mother. Okay, so so usually it affects males because it is X-linked recessive disorder. Now, and it's not only if there is no family history, that does not mean the patient cannot develop mutation in that dystrophin gene. So actually about 30% of cases of Duchenne muscular dystrophy are new mutations in the dystrophin gene on the X chromosome, and then that they will move it into their next generation. So if there is no family history, do not exclude the possibility of a new mutation in the gene. Now, what happens when there is a weakness in the muscle membrane? The muscle fibers are going to go through degeneration. It's not obvious here. I will show you degenerated muscle fibers in the next picture. Now, in this photo, you can see the regenerating muscle. If you look closer, these small muscle fibers, blue muscle fibers, you can see group here, another group in between here. These small blue muscle fibers are actually the regenerating muscles, some new muscles that are trying to regenerate. And we have also a lot of fibrous tissue in between. Usually we don't see any fibrous tissue between skeletal muscles. And we see some muscles that are hypertrophic. Okay, hypertrophic muscles trying again to compensate from in this patient. We don't see inflammation. We see only maybe sparse inflammation or occasional inflammatory cells because it's not myositis, it's dystrophy. This is the trichrome stain here. The trichrome stain, it's to highlight the presence of what? Of fibrous tissue. We saw it on the H&E, but again, we have to appreciate here in the trichrome stain. It's abnormal again. Once you see fibrous tissue between muscle fibers, this is abnormal. It's never normal. Again, what is this cells here? Group. It's fat. We never see fat in normal muscles. We don't see fat in between muscle fibers. So this is a strong hint that this is a muscular dystrophy patient. This is another Duchenne muscular dystrophy. Now, usually in Duchenne muscular dystrophy, it affects first the proximal muscles. It starts in the arms, around the shoulders, in the thighs, and then it moves distally into leg, foot, and distally into forearm and hand. Okay, so it starts proximal, it starts bilateral, it's not unilateral pathology, and it starts at a very young age in Duchenne. It starts at a very young age in childhood, in early childhood, and they are wheelchair bound by the age of 10, and unfortunately they will die by respiratory failure because of what? Because the failure of the diaphragm muscle. We depend on our diaphragm muscle on respiration. So when this muscle is affected, they will die with respiratory failure and with lung pneumonia. So it's a very aggressive problem. Now we said that we have the dystrophin in the where it's localized in the membrane. Here this is from normal muscle, from a normal person, and here we have immunostain that highlights. We have antibodies that highlights against the dystrophin, and that's strong brown circumferential. Okay, it's around the whole circumference of the whole fibers. So this is a normal person, and he have intact dystrophin protein in his muscles. This is the second person. This is a patient with Duchenne muscular dystrophy. We do the same immunostain for dystrophin, and it's negative. If you look at the cell membranes, you don't see the brown staining. It's completely absent in this patient with Duchenne. Now we said we have Duchenne, and we have another one, what we called it, Piquer's dystrophy. Now Piquer's, just like Duchenne, it affects the dystrophin. It's the gene is dystrophin in X chromosome, but the mutation here, it's different. And so the problem in Piquer's muscular dystrophy, they produced smaller amounts of dystrophin. They are not producing enough amounts of dystrophin. So they will have a little bit different manifestation. If you look here at the immunostain, it's covering just part of the circumference of the fibers. If you look here, you can appreciate just a little brown staining on the top here and here. Most of the circumference of the fibers are absent, are negative for the dystrophin immunostain. Now, because of they have a little dystrophin in the membrane, they will have later manifestation. Their disease does not start in their childhood. They may present in adolescent age, and they may they have a long period of survival. They may live into adulthood, okay? Unlike Duchenne, they have more severe manifestation and severe and earlier manifestation, because they have complete absence of the protein. So we covered dystrophies. Now we are going to talk about myositis. Now we said myositis, it's inflammation, and we have to see inflammatory cells. We have two types of myositis. We have polymyositis and dermatomyositis. Now, actually, myositis, it's not due to infectious process. Polymyositis or dermatomyositis, not infectious, it is autoimmune. And here in this patients with polymyositis, we have cytotoxic CD8 positive lymphocytes. All around blue cells are the lymphocytes. Most of them are CD8 positive T cells that are attacking the major histocompatibility complex presenting on the cell membrane of the skeletal muscle fibers, because they are identifying them as foreign when they are the normal cells. Suddenly our immune cells start to identify them as foreign cells and attack them and destroying the muscle fibers. In polymyositis, the inflammatory cells are directly attacking the muscle. But in dermatomyositis, they are not attacking the muscle, they are attacking the capillaries that are feeding the muscles and damaging the small vessels that are feeding the muscles. And of course, when the vascularity is damaged, we will eventually have a muscular damage due to hypoxia, of course, okay? So the muscles here die not because of direct inflammation and direct attack by the lymphocytes, but because of the hypoxia that results from the capillaries damage in that area. And because that in dermatomyositis, it affects the capillaries, the patients have another manifestation, not only muscular manifestation. They will have rash because that affecting the capillaries, especially around in the eyelid. So they have a typical rash, we call it the heliotrope rash. They have a pinkish rash on their eyelids bilaterally. So they have another manifestation in addition to the muscular manifestation. This is another one from polymyositis. The lymphocytes here are attacking the muscle, and here is a degenerating muscle fiber. It appears necrotic, eosinophilic, and irregular. It's not the cell membrane, it's not well defined because it's being attacked by a lot of plasma cells, and here this is a plasma cell, eccentric nucleus, and a lot of T lymphocytes. Now, the most common antibody you have to know that's common the most common antibody in polymyositis is anti-Jo1 antibody. You can do serology for these patients to look for this antibody. Okay. Now moving into soft tissue. One of the most common in soft tissue tumors, one of the most common low-grade tumors is desmoid tumor. Actually, we call in superficial, it has another name. It's called deep fibromatosis because it's fibromatosis. It's abnormal fibromatosis that occur in the deep parts of our body. From its name, fibromatosis or desmoids, it's a fibrous lesion. So the tumor cells are actually fibroblasts. If you look here, the fibroblasts are spindle cells. And in between, we have collagenous stroma deposition because the fibroblast will produce collagen. The problem here, it's not malignant, it's not metastasizing tumor, but it's locally aggressive. It infiltrates in between normal muscle and normal tissue, and it's irregular in margins, and it has no gross definite margins. So when you remove it surgically, you have to take a wide local excision to be sure that we have removed the whole lesion and it will not recur. So the most common problem in these lesions we are afraid of is actually recurrence. We don't afraid of mets or malignant transformation. It's only recurrence and local aggressive behavior. Now, we have types of desmoid. It's either abdominal, intra-abdominal, or extra-abdominal. In the abdominal, it means it's affecting the abdominal wall, and it happens in pregnant women, okay? Extra-abdominal, the most common extra-abdominal sites are the neck, the shoulder, and the chest. Okay, in this upper area, the neck, shoulder, and chest, they present as masses in one of these parts. And sometimes it affects also the thigh. It presents as a thigh mass. So, and you may be afraid that it could be some kind of sarcoma or a malignant tumor. But it's actually not. It's only desmoid tumor. We said it's composed of what? Fibroblast. You look here, the fibroblast are monotonous spindled cells, and in between you have this eosinophilic collagenous stroma between the fibroblastic proliferation. We don't see mitosis, we don't see pleomorphism, we don't see necrosis definitely in them. So we only see some infiltration at the edges. It's infiltrative at the edges, but actually we don't have other features of malignancy. So, and then we diagnose it as desmoid tumor. Now you have going to cover the most common, one of the most common benign tumors, soft tissue tumors, is what? It's lipoma. Now, if you look at this microscopic picture for a lipoma, it's composed of adipocytes, completely normal. Now, if you take fat from our body, fat from anywhere, and diagnose and look at it under the microscope, it will look just the same as lipoma. So how can we differentiate that this is lipoma or normal fat? Grossly, yes, or from the clinical presentation, the surgeon tells us that this is a mass on the neck, or this is a mass on the back or in the scalp. So he's telling us that this is a mass, and he's sure that he removed the mass and sent it to us. Grossly, we see it as completely fat, yellow in color, just like fat. And actually, if you squeeze it grossly, there's oil is going out of these adipocytes and fat cells. So, and you look it under the microscope, it's completely just look like normal adipose tissue. So the only thing to tell that this is a lipoma and not normal is from the clinical history. This is actually very large fatty tissue. This is a huge mass. If you look at here at the bottom, it's 15 centimeter. So it's actually hard for a lipoma to grow in such a lipoma to grow into such a very large size. So we are afraid this is actually is a liposarcoma. But grossly you can identify that this is fat. Why? Because it has this yellow, it's very yellow, fresh yellow in color, and the only yellow tissue in our body is fat. And again, on cut surfaces, it's completely yellow. You squeeze it, there's oil going out of it, and under the microscope, it will be very well differentiated liposarcoma. We have different stages of differentiation: well differentiated, moderately, and poorly differentiated. And even sometimes we have de-differentiated liposarcoma. When it's de-differentiated, you can hardly tell that this is liposarcoma. Okay. This is under the microscope. Here you can see the lipoblast. Now, we do not call them adipocytes in liposarcoma. We call the tumor cells lipoblast. Okay, so here we have lipoblast. The first thing that they are variable in size. We have very small lipoblast and some large lipoblast. So this is unlike normal. The other thing, we have fibrous stroma in between. We don't see fibrous stroma between normal adipocytes. And we have vacuolation inside these lipoblasts, multiple vacuoles. This is another liposarcoma. Here it's more cellular, it's more poorly differentiated. You can easily appreciate the nuclei. If you look in each lipoblast, we have nuclei. If you remember the lipoma, we can hardly see the nuclei. I'm going to go back to the lipoma. Okay, you can hardly appreciate the nuclei because it's pushed because of the fat droplets inside the cytoplasm. You can just maybe appreciate 1 or 2 or 3 in this whole section. But in liposarcoma, the nuclei become more easily appreciated and atypical and hyperchromatic. Sometimes we see necrosis and mitosis. So this is a liposarcoma. One of the commonest sites to know that to have liposarcoma is the retroperitoneum. Actually, we don't have lipomas in the retroperitoneum. Any fat mass in the retroperitoneum, it's liposarcoma. It's either well-differentiated liposarcoma or de-differentiated. We never see lipomas in the retroperitoneum. This is a higher magnification. Look at the lipoblasts. We have multiple small vacuoles. We have a prominent nucleus and cellular tissue. There is pleomorphism in the nuclear size. So this is higher power magnification of liposarcoma. Now, regarding non-neoplastic bone diseases, we are going to go through. We are going to cover the most common non-neoplastic bone diseases after we finish soft tissue and muscles. Now, but here first we are going to know how the normal appearance of bone. Now, you know, normally we have bone trabeculae. And in between bone trabeculae, we have this hematopoietic elements in between. They are actually producing platelets, megakaryocytes. We have progenitor cells that are producing lymphocytes, neutrophils, and macrophages, etc. Now, if you look carefully at the mature bone or mature trabeculae of bone, we call it lamellated bone. Why we call it lamellated bone or trabecular bone? Lamellated because under polarization we will have this bone lamellae. You can appreciate this lines. White lines are actually the osteoid trabeculae, and that they are parallel to each other and going in the same direction. That tells us that this is a mature, benign, normal bone. Now the bone trabeculae, it's form a complex three-dimensional structure. So if you imagine it, it's not only by dimension, it's three-dimension, and that provide the strength to the cortical bone. And these bony spicules, if you see these empty spaces, sparse, occasional empty spaces, are the spaces that containing the osteocytes inside the bone trabeculae. Now, one of the most common pathologies, especially in Caucasians and European population, is the Paget's disease. Now, Paget's disease, it's a disease of elderly. It occurs most of the time, usually above age of 50 it starts, and manifestation come with manifestation 60s, 70s. So it's a disease of elderly population, and it comes in stages. We have the early stage, the mixed stage, and the late sclerotic stage. Now, in the early stage, we have more osteolytic bone destruction and more osteoclastic phase. And then we have the mixed phase when the osteoclast and the osteoplasts are working together. And in the late stage, we have what's called the sclerotic and the burnt out phase. So in this picture, we can see here, what's this type of cell? Multinucleated cell, the osteoclast, and we have here another osteoclast. Here we have osteoclastic activity. They are destructing the bone. So in addition, if you look here at the rimming of this bone, of this osteoid, we have rim, it's rimmed by osteoblasts. So we have both osteoclastic and osteoblastic activity. So this is here, we are in the mixed stage of where you have osteoclastic and osteoblastic activity. Now the problem here is that the osteoblastic activity, the bone and the osteoid being deposited, is abnormal. It's not the normal lamellar mature bone. It's haphazard, it's irregular, it's not mature, it's not lamellated, and we call it a mosaic deposition of bone. And it's actually in a late stage, we have also fibrosis in the same mosaic bone, and that's why we call it the sclerotic bone. Now, this is microscopic appearance under polarized microscopy from a patient with Paget's disease. Now, if you look here to the polarization in comparison with a normal one that we saw previously, now we have masses of osteoid. We don't see the trabeculae, the thin, nice, lamellated trabeculae. It's very thick, it's mosaic, it's tile-like appearance. In addition, the lamellae are haphazard. We have some perpendicular lamellae, and we have other vertical and oblique lamellae. So they are not arranged in the same direction. They are haphazardly arranged. If you want clinically to diagnose Paget's, what's helpful is if you do alkaline phosphatase in these patients, it will be high, but calcium, it will be normal, and the parathyroid hormone in them, it will be normal. Now, another most common, also elderly bone disease is osteoporosis. Now, osteoporosis is very common in our society, okay, and all other societies, not only in our population. And it's common especially where? In female. It's more common in female more than males. Why? Because after post-menopause, when they lost their estrogen production because of post-menopause, they have low estrogen level. The estrogen is very important for the osteoplastic activity and for bone production. And this loss will lead to osteoporosis and weakness in their bones. And also, in addition, with age, the bone trabeculae are getting weaker. So you have the age factor and you have the estrogen factor, and that's why it's very common in this postmenopausal females. What's the problem is that it will lead to weakness of the bone in the vertebral columns, in the hips, in any other bone, and it will be easily fractured. Any minor trauma, it will lead to fracture in that osteoporotic bone. And if you look here to the vertebrae, if you look here in the middle carefully, this is the vertebrae, spongy appearance, brown in color. This is actually the intervertebral discs, okay? White in color, fatty in color, they are the intervertebral discs, just ignore them. Look carefully at the vertebrae. The vertebrae are variable in size. It should be at least the vertebra 3 centimeter. If you look at this one, it's maybe just 1.5 centimeter. So there is thinning in the vertebral column, and this thinning may lead to weakness, any trauma, any minor trauma. It may lead to fracture, and fracture at the vertebral column and the hip joints, it's one of the most dangerous and serious fractures. It's not as easy and as fractures in the peripheral axial skeleton to deal with. So it puts them at a higher risk of fractures. This is an example of patients with compressed fracture in the bone. Why we call it compression fracture? If you look here, because any pressure, it will compress the bone and completely disappear the body of the vertebra. If you look here, the intervertebral discs in the center are attaching each other. There is no vertebral body in between. There is no bone in between, and this is example of vertebral fracture. And maybe a lot of you know somebody with vertebral fractures. They will develop deformity in their axial skeleton. They will have lordosis, okay, or they bend forward, or they bend some abnormal direction in their vertebral column because of this compressed fracture. So compressed fracture, it's common where in osteoporosis, in patients with osteoporosis. This is the type of fracture we have. Now we are going to talk about arthritis and inflammation into the joints. Now if you look here to the left, this is the femoral head. This is how the normal femoral head appears. It was excised from a patient with fracture, not a normal fracture, traumatic fracture, not pathological fracture. If you look carefully at the joint here, you have the femoral head, you have this glistening, rounded and smooth surface. This is normally how joints appears. If you look to the opposite picture on the right, look at this. It's not glistening, it's irregular, it's rough surface, it's yellow in color, not gray, and it's irregular, some elevated and some depressed areas, and it's a burnated surface. So this is example from a patient with femoral head arthritis. So this is the difference between arthritis and normal joints. Now, one of the most common arthritis is what? Is rheumatoid arthritis. Now, rheumatoid arthritis, it's called rheumatoid because they have elevated the rheumatoid factor. When you do in most of these patients, they have maybe 95 of these patients, they have elevated levels of rheumatoid factor. Now, the problem in rheumatoid arthritis is that it affects small joints. So it starts with the small hand joints, and it's bilateral disease. Most of it's bilateral, typically it's bilateral, and it's destructing the small joints. If you look at the fingers here, they are fixed in this position. The joints are destructed, the joints are swollen. If you look at her right hand, this joint is apparently swollen, and there is ulnar deviation. Okay, there is deviation outward in the fingers This is what we call ulnar deviation and swan neck deformity. So it's obvious that this is a distracted joint, and it's also the patient will have manifestation as pain, especially in the morning, especially after she wakes up in the morning, they will have early pain in their hands. Most of the time it affects females more than males in rheumatoid arthritis. It starts with the small joints, but later on it can extend into the large joints. Elbow, knee, shoulder joints, all may be affected, but the most common and the most severely affected are the small joints. Another thing we see in rheumatoid arthritis patients are what we call rheumatoid nodule. If you look here near the elbow, this is the elbow, and this is a pressure point near the elbow. This is a nodule. We call it rheumatoid nodules. It can occur most of the time around joints and in the subcutaneous tissue. They are dermal nodules, but also we can see them even in visceral location, not only in the skin. They can occur in the lung, in the pleura, so they can occur anywhere. Most of the time we see them also around the heel. But it occurs, as we have said, in visceral location like pleura and the lung. Now, what happens in rheumatoid arthritis patients? How the destruction occurs? Now, if you look here at the joint, we have proliferation of synoviocytes. Actually, we have the synovial lining, we call it synoviocyte. The cell type, we call it synoviocyte. We have proliferation of synoviocytes forming papillae. If you look carefully here, there are inflammation, nodules of inflammation. These blue nodules are actually inflammatory cells composed mostly of lymphocytes, macrophages, and plasma cells, a lot of plasma cells. And later on we will have fibrosis. So this is we call it pannus formation, or rheumatoid arthritis pannus. So this pannus and abnormal tissue that destruct the joint and lead to chronic inflammation and destruction and the manifestation that patients have. This is how rheumatoid nodule looks under the microscope. In the center, this material in the center is inophilic material. It's called the fibrin. And it's called fibrinoid necrosis. It occurs most commonly in the subcutaneous tissue, in the dermal sites. So this fibrin material surrounded by cells. These cells are actually epithelioid macrophages, histiocytes, okay, that are surrounding the fibrinoid necrosis, and this is the rheumatoid nodule under the microscope. And it can occur in the lung, it can occur in the pleura. So once you see it, this nodule with fibrinoid necrosis in the center, palisading of macrophages at the edges of necrosis, this is the rheumatoid nodule. Now, another common arthritis is gout disease. Now, gout disease, it's a metabolic problem that affects many parts, not only joints. It may affect the kidneys and other tissue because of what? They have elevated level of what in their blood? Uric acid, excellent. So they have high levels of uric acid due to two problems. Most of the time, metabolism. They have problem in the metabolism of uric acid. That's why it's elevated in their blood. And in addition, they have factors that exacerbate their problem of metabolism. They have a lot of intake of meat, alcohol. They have obesity. So these patients with problems of metabolism of uric acid, they have to be careful. They have to do dietitian consultation, and they have to be watchful for their weight and don't take large amounts of alcohol. So they have elevated uric acid levels, and this uric acid, it will be deposited in the joints as crystals, as sodium urate crystals. If you look here in the center, this pale area is actually crystals of sodium urate crystals. And these crystals, because they are foreign to our body, they will have inflammation and inflammatory cells surrounding them. Actually, all the cells that are around these crystals are multinucleated giant cells here. If you look to the edge of the picture, here multinucleated cells trying to engulf and to get rid of the crystals. And we have macrophages surrounding the gout tophi. We call it tophi. Now, the most common location for gout tophi is around the joints, but they can occur, we can see them in elderly, in the ear, in the face, now everywhere. We can see them in the kidneys, the uric acid crystals in the kidney. They will destruct the kidney and they will lead to renal failure, and this is a bigger problem than arthritis. Now, the most common affected joint is what? It's the big toe joint. And it's deposit anywhere around the joint, in the tendons, in the joint ligaments, in the soft tissue around the joint, and they will present with severe pain in their joints. Now, if you do aspiration to this patient, if you suspect gout, for example, if the patient comes to your clinic and you suspect that this is gout, you may do fine needle aspiration from the synovial fluid and send it to pathology. And under pathology, they will examine it under the polarized microscopy. Now, this is a picture from polarized microscopy, not normal microscope. And under there is a red compensator in the polarized microscopy. The needles, here how the crystals, they will look needle in shape. Okay, variable in size, but all of them are needle in shape. The one that go with the compensator are yellow in color, and the one that go in the opposite direction, they will be blue in color. Okay, so this is how they diagnose it, from just aspiration to the fluid in the joint. We have another condition that we call pseudogout. Pseudogout, why? Because the crystals being deposited are not sodium urate crystals, are different type of crystals. We call these crystals calcium pyrophosphate dihydrate crystals, CPPD. It's usually less severe than gout, and it have a later presentation than gout. So it's a pattern in presentation. Pseudogout, it's better than gout. It's a progressive disease. It destructs the joint because of the deposition of this calcium pyrophosphate dihydrate crystals, but it takes a lot of time before presentation. It affects the large joints, knees, wrists, elbows, shoulders, and it starts after the age of 50. It does not start early in life. So it's destructive, but it's slower. The process is slower than those with gout disease. Okay, I think this is the last slide. Any question? Thank you.